Well, the first one was successful. Let's see if we can make the second one successful. Slideshow from current slide. Okay, this is where we decided to stop at so we could have plenty of space. Alright, your second one of your increased blood flow to the lungs, or increased pulmonary blood flow, is your atrial septal defect. So the atrial septal defect you can actually see in this pretty little picture here. These used to play, these little arrows would show you which way it was going, but I think that with the transference from a web page to a PowerPoint kind of made it bad. So it tells you where all your little parts are. You know, your left ventricle, your right ventricle, and you can see that with unlike the other defect, the patent ductus arteriosus, where the right side of the heart was smaller than the left side of the heart because the left side of the heart had more pressure gradient in it, you can see that there is a difference here. The right side is enlarging. So what's happening here with the atrial septal defect, you have a higher pressure gradient in your left side of the heart. There's an opening in the atrium, the left atrium and the right atrium. That's in the septum. So it's called a septum defect. The oxygenated blood is mixing with the deoxygenated blood as the patent ductus arteriosus did, except it's just in a different area of the heart. So there's more blood flowing into the right ventricle, and the right ventricle's having to work harder to pump out the blood to the lungs so that the right ventricle enlarges, and then you have this mixed oxygenation, mix of oxygenated and deoxygenated blood going again to the lungs where it should only be deoxygenated blood. So the deoxygenated blood that's supposed to go and the added oxygenated blood that's going causes that increased blood flow to the lungs. So this would fall into that category. And to fix it, again, is a simple fix. A lot of children reach adulthood and never know that they have an ASD or a PDA. Never know it because it doesn't have that cyanotic effect. It's acyanotic. They don't get the only thing that they may have is that later on, if it doesn't get fixed, depending upon how big the defect is whether or not they will start having clinical manifestations and go into congestive heart failure. This one right here is a little booger with women who get pregnant because they have all that extra fluid, and these that are causing increased blood flow to the lungs can really cause these moms to have some problems. So you can see how the patch looks really right here, and they're showing you how once it's closed, and once it is closed, again, it's preventing oxygenated blood from entering the deoxygenated blood, which is very important. That will help us to get rid of the increased blood flow to the lungs. And then our ventricle septal defect is going to work the same way. Basically, your pressure from the right side of the heart, which is higher, the left side of the heart, excuse me, left side of the heart has higher pressure than the right. And you're going to see a spillover with the septal defect, much like the atrial defect. The same thing happens, except here we're seeing both ventricles enlarge because of the work that both sides of the heart has to do because it's a septal defect. The septal part of the heart is where your major pump action comes from. So this is why we see those actually becoming hypertrophied. So again, oxygenated blood in with deoxygenated blood, causing an increased blood flow to the lungs, increased pulmonary blood flow. So again, we have that mix. Again, we would have no symptoms, maybe a murmur, maybe a mechanical type murmur, but no clinical manifestations as far as cyanosis, or because this is an acyanotic or increased blood flow to the lung uh, category. And here's how we fix it. Much like you fix the atrial defect, you just put a little patch in there. So what do they use for patches? They have synthetic type skin things that they can put in there. They can also use a some pork valves if they think that a valve would hold it. But most of the time they just use a little synthetic type of skin, or possibly some cadaver skin, something that will continue to grow with the baby. Alright, so now we are going to talk about decreased pulmonary blood flow. And before we talk about that, I kind of like to talk about, we're talking about all these little congenital defects, and we're having to do this is the difference in the pediatrics and the adults. So, what are some other reasons why the pediatric cardiac is different than adults? Well, for one thing, the heart's at greater risk for heart failure in an infant than it is with an older child, because the infant's heart is less developed and less organized, because it's been doing that little fetal circulation thing, and it's not really had to do anything but just kind of beat. It's not really had to do much else, just kind of have that little beat going on there. Then infant's heart has less compliance, which means the ventricles don't stretch to increase stroke volume. They use increased heart rate. Our little infants have around 140, 160 heart rate. They usually can't actually increase their stroke volume until they are around the age of 5, when the heart is considered to be fully developed. Usually, at birth, their metabolic rate and oxygen requirements double from what they were, because the heart's now working with the lungs. And that's why their heart rate's high, is maintaining the cardiac output. And there's very little reserve for these infants. Hematocrit and hemoglobin concentration is going to be unique to the age of the child. If it's too low, desaturation will occur. And when you have desaturation of the blood in an infant, what usually happens is that the increase demand for oxygen occurs, and that increased demand triggers the response of making more red blood cells, and you start seeing the blood thicken. So you're starting to see polycythemia. Polycythemia leads to the high risk of having a stroke or congestive heart failure. And one of the things that you want to be sure with any child that's having a hypoxic type cardiac defect is to be sure that they stay hydrated. You always want to hydrate these babies. Be sure that you are thinning out their blood with making sure that they're hydrated. Alright, let's talk about the decreased pulmonary blood flow. And there is a page somewhere in your book. Let's see. You actually have an excellent summary with the pages in your book that shows you the cardiac defects and tells you all the pathophysiology of each one of them. And it starts out, of course, with the increased blood flow, because these are actually the ones that we don't worry as much about as we do the others, because we are still having, with this increased pulmonary blood flow, we're usually going to see that they stay pink and pretty, and they don't usually show signs of that. So it's really a good, it's a good thing to look over. And in fact, I've referred y'all to do this a lot of times with the other ones. So decreased pulmonary blood flow is, of course, when there is blood that's obstructed to that results in little or no blood getting to the lungs. That's what we are concerned about. And so some of your obstructed blood flows are the tetralogy of Fallot and tricuspid atresia. And the only one I'm really concerned about is the tetralogy of Fallot. Depending on the defects, there's always, tetralogy of Fallot means that there are 4 defects there. So depending on our defects, it depends on how much we're going to see the blood flow. So usually when we see an arterial or ventricle septal opening between the left and the right side of the heart, and the pressure in the right side is higher than in the left, then we're going to see cyanosis. With tetralogy of Fallot, we see pulmonic stenosis, right ventricular hypertrophy, ventricle septal defect, and an overriding aorta. The hypoxic and cyanotic manifestations are going to appear as the ductus closes. You'll hear a systolic murmur in the pulmonic area. You're going to see polycythemia, hypoxic spells, metabolic acidosis, failure to thrive, and you're going to see some maybe poor the clubbing of the fingers if it gets to be such. And that's basically what happens in an adult when they have cardiac disease for so long. Then that's usually what you're going to see happen. I delivered a tetralogy of Fallot baby all by my little self. Patient came in complete, called the doctor, and the patient, while I was getting a little bit of history, while I was frantically putting her in the bed and placing her on the fetal monitor, if I possibly could get her on there and get an IV started, was, oh, by the way, she was from out of town, said the doctor that I'm going to said that my baby has something wrong with it. It's something to do with 4. Has 4 defects. Of course, tetralogy of Fallot is the first thing pops in my mind. And I'm thinking, I am going to do a nurse delivery with a tetralogy of Fallot baby. I do not want to do a baby with tetralogy of Fallot. Please let the doctor get here. So while we're waiting, those infinite seconds go by that seems like hours. Seems like we're, just have hours and hours when just seconds go by. I keep waiting for the fall of the footsteps outside the door. And now, instead of praying for the obstetrician, I'm praying, please let the pediatrician get here. Please let the pediatrician get here. Well, neither one of them showed up for the delivery, and here comes the baby. And I take the baby, who is awake, whose eyes are wide open. He's not crying, but he's not blue, and he's breathing quite well. And I gently put him into the little warmer, and I leave him alone. I don't touch him. I don't stimulate him. I'm like, you're looking good. You're just going to leave you alone until something bad happens. And so about 5 minutes pass. He's still looking good. 5 more minutes pass, and the obstetrical doctor gets there. And then my pediatrician gets there. And I am so glad to see my pediatrician. It is just, we attempted one time to start an IV. It made the baby cry. He turned a little blue. We stopped. So why was my baby pink? Why didn't my baby turn blue because of the decreased pulmonary blood flow? The major reason he didn't turn blue is because his ductus hasn't closed and his foramen ovale hadn't closed, and he had enough blood flow between the ventricular septal defect from the right to the left side of the heart that he managed to stay oxygenated. Had that ductus closed and the foramen ovale closed, this baby would have been in major, major distress. And I was just thankful to have those two defects. So I wanted to keep, you know, if I don't want them to close, I needed to give that baby something to keep them from it. And usually we give prostaglandin E to help keep that patent ductus patent until we can get them to where they can have surgery and be able to uh, do that. So the times that we see when we begin to see them become hypoxic and cyanotic is when that ductus closes. So that's the main reason why my baby did not. We didn't stimulate him to make him have that uh, desire to close that patent ductus, which like I said, am so thankful for. So basically, what the four um, disorders are, or defects are, we have this thick right atrium, we have a VSD, and you can see the pressure over here in the right side of the heart is greater than the left side of the heart. So, and the reason being is you have reduced blood flow. You have pulmonic stenosis, where this pulmonic artery is smaller. It may be stenosed right down here. It may be stenosed all the way up, but it's preventing blood from the right side of the heart to go up into the go up into the lungs to be able to get oxygenated. So we are looking at a pressure gradient buildup here that's going to push the deoxygenated blood over into what oxygenated blood we do have, and it is definitely a big mix of oxygenated and deoxygenated blood. If we have our little patent ductus here, then our part of our oxygenated blood would be going, at least have an exchange here. Um, and then we would see at least the baby would be able to survive till we get to surgery. Have an overriding aorta. See how large this aorta is, and it's overriding into the the left ventricle, and the causing the atrium to be the atrial septal valve to be smaller than it should be. So we have the thick pulmonic valve, we have thick right ventricle, we have septal defect, we had an overriding aorta, and these are all things that are going to cause us to have cause this baby are part of the tetralogy of Fallot. How do we fix it? Well, it's amazing because before, like I said, this baby was just left on its own devices, and you gave comfort care. So right here, we're gonna widen this artery, this pulmonary artery, by putting in a patch. You know, it's kind of like when your pants are too small, you can just cut them open and put a little patch in there and make them bigger. And of course, the area below the valve, we wanted to make sure we widen it. And then, of course, we repair the VDS. Well, what are we going to do about the right ventricular hypertrophy? Well, there's not anything we can do about this. This is just going to be part of his circulatory system, because we can't go in and enlarge it to make it, or we can't go in and fix it. The muscle itself is already enlarged, and we can't just go in there and fix that muscle, which I think is just pretty awesome. All right. I want to go back to the, if I can. Okay, let's talk about the tetralogy of Fallot. Just a little bit more about this. one thing I want to bring up about the tetralogy of Fallot is the fact that the tetralogy of Fallot, once once they have tetralogy of Fallot, even with the some children can actually live as long as the ductus and things remain open, but they are still surviving on small amounts of oxygenated blood. So it's very common for them to have TET spells or blue spells. And if a child is older and we've not been able to get them into heart surgery for whatever reason um, it may be that their heart is in such bad shape they're on the heart transplant list. Like I said, it just really depends on uh, the quality of the defects. So most of your older children are going to squat. You'll see them squatting when they've been at play and they get out of breath and they start turning blue. They'll squat, and the reason they squat is just a natural reaction to stop blood flow down to your venous stop blood flow down to your lower extremities and increase the blood flow to your upper extremities, and this helps them breathe better. It helps them oxygenate better. Infants and toddlers who don't know how to do that, if you have an infant having one of those TET spells, like, you bring him into he's been brought into your office for a blood draw, and you start to stick him, and he starts crying, and then he starts uh, turning blue. He needs to be taken out of the carrier. He should be always been in his infant carrier in an upright position anytime that you do any type of nursing care to these babies. You need to hold them in a knee chest position. Most infants draw their knees up to their chest in response to pain. It's a normal fetal position for them, and that's the position they need to be in to help them get through these TED spells. Is that all we need to do to TED spells? No, there's a whole lot of things we need to do for TED spells, such as we need to teach the parents how to do oxygen. We want to make sure they know CPR. We want to make sure they know when to call and have the hotlines ready. All of these things need to be done, but this is one of the first things you can do that may prevent all the rest of those things happening. Um, Sometimes just feeding an infant with a cyanotic episode can cause them to uh, have a cyanotic episode, because feeding takes a lot of energy, and sometimes they hold their breath when they nurse, and so you know, it can affect their cyanosis. Always remember that feeding is something that does affect how these babies' oxygenation occurs. They spend a lot of energy on eating, and therefore they spend a lot of their calories that should be going to their body systems that's been wasted trying to feed, so they become failure to thrive babies. And the body loses what blood supply it should be getting to support the lungs and the heart, because it's all going into the effort to try to intake calories to support the body. So of course, one of the other things that we can do is make sure that their formula or their breast milk is supplemented with increased calories, so that if they eat 1 ounce instead of the 20 calories that's in a bottle, we can raise it to 24, 26 calories, even up to 30 or more if we need to. Alright, I just had to go back and do that. Alright, our little mixed blood flows. We have complex defects that have different degrees of cyanosis and CHF. So it's really kind of the reason they put these in this particular category is because they really weren't able to find a place that it actually fit in very well. So we came up with the mixed defects. Basically, of course, we've already talked about tetralogy of Fallot as one of those, and We may see a different degree of congestive heart failure and cyanosis related to the possibility of the ductus being open and the foraminal valley not closing. It allows the blood to mix enough to keep the babies oxygenated so that they're not as cyanotic, or that they can live on that particular type of, without having increased activity. So when the pulmonary vascular resistance is lower than the systemic system, we're going to see pulmonary congestion develop. That's going to lead to our congestive heart failure. If the pulmonary resistance is higher than the systemic, which means that the lungs aren't allowing as much blood to come into the lungs as they are to the systemic, we have pulmonary blood flow decreased, causing more severe cyanosis and polycythemia. Polycythemia is a bad thing. Some of the manifestations that we're going to see with these mixed blood flow defects, such as tetralogy of Fallot, is cyanosis at birth that doesn't improve with oxygen. So if you're putting oxygen on a baby because it's blue, even though it's breathing and it's blue, and you put oxygen on it, it's not going to improve. If we have the ventricle septal defect, they're less cyanotic because we have the mixing of the blood. You will only hear a murmur if there is a VSD present. Of course, they're going to be very tachypnic, and they are probably also going to be tachycardic, because when they're tachypnic, it means they're not getting enough blood flow. So these are things that you kind of want to be looking for. And these particular types of defects usually will lead to have some severe cyanosis in the first day of life, and later they start having the congestive heart failure. So it really has to be monitored very closely with these mixed blood flows. Usually it's a quick fix with the decreased and increased defects, but it's really with the mixed defects, you have so many different defects that you have to try to deal with that it becomes difficult to determine what your right course of action should be. So let's look at one of the others besides tetralogy of Fallot. This is a simple transposition. Now the tetralogy of Fallot is decreased blood flow. Yeah. So remember, the tetralogy of Fallot is the only one with decreased blood flow we're really going to talk about. These are the ones with the mixed defects. Even though tetralogy of Fallot has 4 defects, they are all decreased pulmonary blood flow. The other defects that we want to see in tetralogy of Fallot are increased pulmonary blood flow defects. These are a mix that you just don't know what is happening, and they'll usually present the way we just talked about. This is a simple transposition. To just look at this picture, it's kind of hard to say, well, what's going on here? Well, this particular, the aorta, is it supposed to be here? And the pulmonary artery is supposed to be here? Remember, the pulmonary artery carries the deoxygenated blood from the right side of the heart to the lungs to be oxygenated. The left side of the heart pumps blood into the aorta to carry oxygen to the rest of the body system. So in this system, we are continually pumping deoxygenated blood in a circle constantly to the systemic system. The only saving grace here for our infant is our atrial septal defect. That is allowing oxygenated and deoxygenated blood to mix, depending on how much of a mix this is. And if we had the patent ductus, it would help also, but we don't. We have this little atrial septal defect. So basically the oxygenated blood is going to the lungs and coming back to the left side of the heart and going back to the lungs, and it's a continual circle. Same thing with deoxygenated blood's going out to the body system, and it's getting a little bit of oxygenated blood from this septal defect. So I mean from this atrial defect, and it's going circle with just a little bit of oxygenated blood from there. So you can see how that that is definitely a very mixed defect going on there. We have some oxygenation, but a very bad defect going on there. That defect um, is incompatible with life, especially if there wasn't a um, atrial defect there to allow an oxygenated blood to pass through. That would be probably the baby would die before we could ever get them to where they need to be for surgery. And of course nowadays with the fetal ultrasounds being as good as they are, a lot of times we already know, and we may have them at where they need to be when they deliver. It's very important when you have a patient with mixed blood or mixed defects to reduce stressors. In fact, it's important with all these defects. You don't want to have any stressors whatsoever on these babies with these defects. You don't want them to cry. You don't want to engage them too long. As long as you have an open flow of blood, they'll actually be able to have some mixture of oxygen and deoxygenated blood. But if you stress them, it's going to increase their cardiac workload, and then they're going to need more oxygenated blood than's being supplied. So you want to be sure and keep that in mind. And one of the um, cardinal signs of transposition of the great vessels is you're not going to see any improvement whatsoever if you add oxygen, because if you're adding oxygen and the baby's breathing in the oxygen, all it's going to do is go straight into the pulmonary arteries. They're going to be carrying it from the lungs. There's not going to be any oxygenated blood coming out, so it doesn't make any difference if you add oxygen. If we do have a PDA, which we love to have one of those to keep as much oxygenated blood and with the deoxygenated blood as we can, we'll give them prostaglandin E1, I guess. Um, until we can actually do surgery. Surgery, of course, is going to involve switching those arteries. We're going to have the pulmonary artery put back onto the right side of the heart, and the aorta put back on the left side of the heart. And they can't survive without surgery. Hypoplastic left heart. I've had several babies with hypoplastic left heart, or delivered them. I haven't had them. And it's amazing that, again, this is a mixed defect. And it's amazing how these can actually present themselves, and you really don't see any difference when they're first born. They seem pretty normal. Of course, as they're getting older, that patent ductus arteriosus is going to close. And once that closes, then we don't have our mixture of blood. So let's see what's going on here. We have a small aorta, which is a bad thing. We have an atrial septal defect. We have narrow mitral valve. We have a small left ventricle, which means the gradient will be less on the left side than the right side. So basically, hypoplastic left heart. The left heart's just almost unable to function, and it's trying to push up against the blood flow going up to the aorta that is got a blocked aortic valve, and it looks like some stenosis going on. So you see it has a lot of defects in here. The ASD is the only thing that's keeping this baby oxygenated, and the patent ductus is what's working to keep oxygenated blood going out to the body system, because it's leaking here from this artery. You get oxygenated blood from the left atrium to the right atrium, and then it's mixing, and then it's going to, instead of mixing with our deoxygenated blood, and then when it goes up the pulmonary artery, the deoxygenated blood carries a little bit of oxygenated blood with it. And so this little bit of oxygenated blood from the left side of the heart is going to go up, hopefully enough, through the patent ductus arteriosus to keep our baby oxygenated enough that survival can be. Now, some babies are born with this defect and they can die within days. Some babies can live for weeks. I had one infant that we did palliative care, because when this infant was born, I was early in my career and nothing was done for hypoplastic left heart except for heart transplant. And a lot of these babies don't qualify for heart transplant because of damage done to their body systems because of the lack of oxygen. So they don't want to waste an infant heart on someone that their body systems can't support it either. But now we do have surgeries, and I'm not going to go through all the surgeries that we have for these. If you Google hypoplastic left heart, you will find out that there are a lot of babies that go through these procedures, and these procedures are not always, they don't work 100% of the time. What happens is that usually the surgery they go through, they may develop problems from the surgery, such as infection, or they may not take. So a lot of these things are, they have to have multiple surgeries. They have to have like three certain surgeries done in a period of time. So they'll go in and they will repair one of the defects. Now they can't do anything with, of course, this small left ventricle, but they can go in and they can repair. They can go in and do the same thing for the small aorta. They can put a patch in there. They can go in and unblock the aortic valve. They can do some type of surgery here. I think it's called the Norwood surgery. But there are actually families that are blogging on the web about their child having hypoplastic left heart and the surgeries that they've gone through and the progression of how their child does. And there's several of them that I read that their child went through multiple surgeries and still did not live through it. The best thing for this, of course, is heart surgery and or heart transplant. So if you can get a heart transplant for a hypoplastic left heart, it'll take care of everything that's going on here. The thing you have to watch for then is heart transplant rejection. And of course, as they get older, if the heart doesn't grow with them, which normally it will, if it's been in there to be just like it was in the same body it came out of, it will normally grow with them. But even later on in life, it can actually reject. So it's a lifetime full of a lot of surgeries, a lot of interventions. Okay, so clinical consequences of having congenital heart disease. The major one, of course, is heart failure. The inability of the heart to pump an adequate amount of blood to the systemic circulation. In children, It's usually secondary to those anomalies that result in the increased pulmonary blood flow. Because when you have increased pulmonary blood flow, then you start seeing inability of the right part and the left part of the heart to pump effectively because of too much fluid backing up. Too much fluid in the lungs causes too much stress on the right side of the heart, which then in turn stresses out the left side of the heart. We can also see myocardial infarction, cardiomyopathy. All of these things we can see. Our left-sided failure, of course, I think you would have learned this with Miss Lindsay, but it's when that left ventricle is not going to be able to pump the blood into the systemic circulation. Of course, that causes pressure in the left atrium to increase and in the pulmonary veins. So that causes the lungs to become congested with blood, which is going to elevate the pulmonary pressure, and that's going to cause pulmonary edema. Once we get pulmonary edema, we're in pretty bad shape. The right-sided failure is when we're unable to pump blood effectively into that pulmonary artery, which is the deoxygenated blood going to the lungs. So it increases pressure in the right atrium. It causes systemic hypertension, resulting in hepatosplenomegaly and sometimes edema. A lot of times edema. With right-sided heart failure, edema is one of your things that you're going to actually see occurring with that. Our therapeutic management, I'm going to talk about this and then we're going to stop and trade off. As with adults, digoxin is a really great drug. Its course major job is that it increases the contractility of the heart. And we also have ACE inhibitors that we use. Your page 839 has a lot of toxicity signs and what to teach the family about administering digoxin. So please know that. Of course, one of our second therapeutic one is to get rid of the accumulated fluids and sodiums that the body accumulates from the lack of cardiac function. We usually give Lasix to children. We usually give Lasix to adults. So when we're giving Lasix and digoxin together, we're going to see Lasix causing, because it is a loop diuretic, it does not spare potassium. So we're going to see maybe a fall in that potassium that will cause an increase in our dig uptake. So if we have hyperkalemia, it decreases the dig uptake. If we have hypokalemia, it decreases the dig uptake. Wait a minute. A fall increases dig uptake. A rise decreases. I'll get it right here in a minute. Hypo causes an increase in the dig uptake, and hyper is going to cause a decrease. So either way, you've got to watch those potassium levels, because we want the dig to be effective. We want the dig not to be toxic. So we want to make sure that we're looking at that. Another thing we need to do is decrease cardiac demands. We want to provide a neutral thermal environment. We don't, especially with infants, they need to be kept warm. They don't need to, their body does not need to try to keep itself warm by using up all their fat stores. We want to treat all their infections immediately because they can develop into endocarditis, which is a bad thing. Reduce efforts of breathing. The way we do that is we make sure they have oxygen. We make sure they're not having too much activity. We may have to use sedatives to decrease their efforts to breathe. Want to make sure we're providing rest and we're going to decrease activity. Now, with all of this, it's pretty hard for a child to actually have growth and development in the proper stages. So it's something we really have to kind of weigh the benefits and the risks. And of course, that improve the tissue oxygenation. We want to have supplemental cool humidified oxygen. Should always be cool, humidified. Even though in the nursery they will actually warm up the air, but when they get to this point when it's their heart, they want the cool oxygenated one. So what do you think that our highest nursing diagnosis would be here? Our highest nursing diagnosis, there's a lot of things that's important. Fatigue, sleep, activity intolerance, those are all important because fatigue is a bad thing. It causes them to use up more calories and then causes more stress on the heart. But our most important one deals with our ABCs. We always want to make sure that we're having circulation and airway. So altered tissue perfusion is going to be our number one nursing diagnosis. Altered tissue perfusion is what's going to reflect that we know that the heart is not able to compensate for the defects that's going on, and they need, or the congestive heart failure, whichever's going on, and we need to make sure that we continue with proper oxygenation of the tissue. All the other things preventing them will help us keep tissue perfusion at its best. So that's one of the things you really need to kind of take care of. Now with the digoxin, Miss Candler or Miss Lindsay's gone over the digoxin with you. Most thing you need to remember with about children is that if you're figuring out a dig dose and you get 3 or 4 milliliters, you're probably figuring it wrong. It's usually a very small amount. So, be that, if you're giving dig to a kid and you pulled up 2 milliliters, you need to go recheck your math and not give that to an infant or question anybody that's given that amount because dig does not usually take that much, especially if they're on a maintenance dose. Um, You also, when you're giving digoxin, need to give it straight up. You just give them the digoxin. You can follow that with a drink of water to take the bad taste out of their mouth, because dig is noted for its horrible burning taste. You can't mix any, you surely shouldn't mix any medication in food or formula because you don't ever know if they're going to take all of it. You have to know how much exactly digoxin they take, and since it's given in such a small amount, you don't want to mix it with anything. Sometimes the child may vomit after they take their dig. Don't give them a second dose. You don't know how much they got absorbed before they vomited. And another thing, vomiting is a sign of dig toxicity. So you want to be sure and read that page on 839. How do we know if our diuretics are working? Well, if diuretics are being given because we have excess fluid volume, and then we see a decrease in our fluid volume that's supported by weight loss, then we know that the Lasix is working. We don't have to do any labs or anything. We can just weigh the patient, and if they have lost weight, then we know we've gotten rid of the excess fluid volume. It's going to decrease the workload of the heart, which we're really happy about by getting rid of all that excess fluid. And so we need to teach the parents about the importance of them giving the diuretics. So what kind of diet do you think that these patients should be on? Well, we're looking at a fall in potassium because of the Lasix. We're looking at an increase in sodium because of the cardiac function, and it's not giving our kidneys enough oxygen to actually do its best job. So we're looking at that. So we're looking at too much sodium, not enough potassium. So a diet for a child should be higher in potassium and low in sodium for a child that's having to take dig for congestive heart failure. So be sure you know what kinds of food will increase potassium and decrease sodium. And even though we know that our child may not eat that particular diet, that is the diet we would choose. We'll go this one and then we'll go to hypoxemia. Nursing care for these patients with congestive heart failure. Always assist in those measures that are going to improve cardiac function. Always monitor afterload reduction. We want to decrease cardiac demands, reduce those respiratory distress, maintain their nutritional status, assist in measures to promote fluid loss and support the child and family. This is basically a summation of what we just talked about. So I'm going to stop here and we are going to record it, hopefully. Yay.